Karen Scott with TruCode, and thank you so much for being here with us today. We are so excited that you are here for the ICD-10-PCS. Where are we? Heading into year number 2. And so again, thanks so much to Joy King Ewing for doing this presentation. Before I introduce Joy, I want to just do a couple of housekeeping issues for you today. And first off, just a little bit about Webinar Control Panel. Over to the right side of your screen, you will see a little panel, and that's where you're going to be able to ask questions. You are all in listen-only mode, and so the way to ask questions, I'll show that in just a minute. But basically, if that panel is in your way, it's covering up some of the screen, then all you need to do is just click on the little, where the arrow is pointing to, the little orange box with the arrow in it. Just click on that and that will move it out of your way. If you want to ask a question, just click that back open again. And then if you go down toward the bottom, underneath the poll question, it'll have questions, and you can just click on that. It's actually, instead of a little minus sign, it's actually a pointing in a triangle there. Under questions, just click on questions, and then it'll open up a little box just like it shows here today, and you can type your question in there. Again, you're in listen only mode, so please type your questions in, and we will be addressing those at the end of the presentation. So please make sure you do that. You will, if you need handouts today, they are right beneath the question button. There is a handout button. Again, this is in your control panel on the right side of your screen. Right underneath question button, there is a handout button, and you can click on it there. It shows handouts navigating ICD-10-PCS. So that's where your handouts are, right there on your navigation screen, on the right side of your screen. Also, you will be getting a survey tomorrow. Now, that survey is an evaluation form. We always like to know what you think and what types of sessions you would like to see in the future. And also, once you fill out that CE certificate, then you will, or excuse me, once you fill out your survey, then you will get a CE certificate after that. So I know we get a lot of questions on that. So again, you won't have your CE today. You will get an email tomorrow, and so then you will get, once you fill out that evaluation form, send it in and you'll get your CE. If there are multiple people in the same room, then you need to let us know that, and so we will let you know at that point in time on how to get your CE credits for that. So again, let us know. But basically, you won't get anything from us until tomorrow. So let me go ahead and introduce Joy to you. It's my pleasure to introduce Joy, and she has over 20 years of experience in health information management with specialized education and experience in inpatient coding. She received her Bachelor of Science degree in Health Information Management from the University of Tennessee. She served as a consultant for the Alabama Quality Assurance Foundation and Florida Medical Quality Assurance and the Florida QIO for several years. She's taught coding workshops and oversaw all coding activities related to PEP under the different areas there, and she's done a lot of coding education. She's made many presentations to medical staffs across the state, and also speaking on documentation, coding issues, and medical necessity. Joy is past president of the Alabama Health Information Management Association, distinguished member of that same organization for 2003, and served on the CSA task force for the American Health Information Management Association. She's an independent contractor. She has her own consulting firm, and she offers presentations related to clinical documentation, severity adjusted DRGs, present on admission indicators, and pay for performance topics related to upcoming changes. We are so excited that she is a part of our team, and thank you, Joy, for being with us today and presenting this awesome presentation for us. I'll turn it over to you.
Thank you, Karen. I appreciate the introduction and the kind words, and let's go ahead and get started. I want to start with just touching on some of the more significant PCS changes that went into effect October 1 for this fiscal year that we're in, and then I want to go into the majority of the presentation looking at areas of confusion and error that they found in the first year's data with coding with PCS, and try to touch on some of those areas and kind of try to clarify some of the confusion that's out there. As you can see, there were 3,827 new PCS codes that went into effect for fiscal year 2017. Most of the changes were in the cardiovascular system. They added some different device values. They added bifurcation as a qualifier, some more body parts. And in particular, they did a whole lot of stuff in order to be able to code correcting congenital cardiac defects. So a lot of the changes aren't necessarily going to be things that you are going to be using on a day-to-day basis if you don't work in a facility that does a lot of those congenital defect procedures. However, there are some that are significant that we're going to kind of touch on. First of all, I wanted to start with control, which is one of the root operations that they expanded the definition of control. Prior to October 1, it was only related to stopping or attempting to stop post-procedural bleeding. And as you can see, October 1, they added in the additional wording of or other acute bleeding. So they have now expanded that root operation of control to be more than just post-procedural bleeding, but any type of acute bleeding that they're trying to control. And it goes on to say in the guideline that if an attempt to stop the post-procedural or other acute bleeding is initially unsuccessful, and they have to go and do another definitive procedure with one of the other root operations, then you would code it to one of those root operations rather than to the root operation for control. They also made a change in the way that we are doing body parts for coronary bypass grafts. Previously, the guideline had said that we were going to code the coronary arteries classified by the number of distinct sites treated. They basically have eliminated that so that we are going to be counting coronary arteries treated rather than sites treated. So basically what they have done here with this guideline is to talk about the difference between coronary artery bypass procedures as opposed to other bypass procedures, and that rather than identifying the body part bypassed from, the body part identifies the number of coronary arteries that were bypassed to, and the qualifier specifies the vessel bypassed from. We will be counting the coronary arteries based on the names documented in the operative report rather than sites treated. This slide lists all the coronary arteries, the main ones, as well as all the smaller branches as well. So make yourself familiar with these if you happen to be coding procedures, CABG procedures for a facility. Also, a couple of other things that they did. The table for PTCA was revised so that now the device character reflects the number of stents that were put into the body with the PTCA. Prior to that, we were not counting the number of stents. And so I've just kind of circled there a couple of those to show you that it has 2, 3, and then 4 or more stents involved in a PTCA. Also, I mentioned previously about the bifurcation qualifier being added to several tables. The tables that have had that added are listed on the slide for you, and I've got it circled out there in the qualifier slot. Remember that when a procedure is done on the bifurcation or the forking of a vessel, it's more complex. It requires more effort by the surgeon and probably more time, etc. So it's important to try to capture that information in terms of reflecting severity of what the surgeon is doing, as well as how that's going to play out in revised reimbursement going forward. They also have several new types of stents that they are using for abdominal aneurysm repair. These do only apply to abdominal aneurysms currently, but likely they will be expanded to other types of aneurysms at some point in the future. The new types of stents are listed here for you. Bifurcated is where they place it in the aortic bifurcation, the abdominal aorta, and the main stent branches go into the left and right common iliac arteries that go down into the legs to supply the legs with the blood. Then there is a branch stent that has nubs that extend off the main stent. Again, the main stent is going into the abdominal aorta, and those nubs extend into the arteries that branch off to make sure that they are not blocked and the blood is flowing through there like it should. Fenestrated is another type of stent that they talked about. Those have little windows or openings along the stent, again, to make sure that the blood is flowing through the vessels. And the interesting thing about these last two, the fenestrated and the fenestrated scallop, is those are patient specific. They have to actually put the stent in there and measure it to make sure it specifically fits that the anatomy of that particular patient. And of course that certainly does help if you're trying to precisely align it with the vessels, and you have a lot more chance of making sure that you are repairing the aneurysm but also allowing for proper blood flow. The fenestrated scallop at the bottom has a U-shaped cutout in the proximal end of the stent. And the good advantage of that is that you can place that main part of the stent higher up in the diseased aorta, as well as having the scallops and the fenestrations to make sure that the blood is properly flowing through there. You can see a lot more detail about these stents in the fourth quarter 16 coding clinic. And just to show you how it shows up in the tables, they have added in the device character. You don't have to choose whether it's a branched or a fenestrated aneurysm, or stent rather. You just have to choose how many different arteries are treated. So you can see there that intraliminal device, branched or fenestrated, 1 or 2 arteries, and then another character for 3 or more arteries. In the orthopedic section, they made a couple of things. Prior to October 1, as you know, the hip joint and the knee joint have different components that are replaced, but there was not any way to code a revision or removal if they went in and wanted to remove either the femoral or the tibial or the patellar component, etc. You couldn't really do that. So in October 1, we had some revisions made. We have some new body parts, so that we are now able to code revision of the different components of a hip joint or hip replacement and a knee replacement. And again, at the bottom of the slide, you can see the tables that were affected by that change. The other thing that they did was to allow us to be able to code a hemiarthroplasty or a unicondylar knee replacement. We weren't able to do that prior to October 1. So instead of replacing both the medial and lateral condyles, they will replace only one or the other. So the way that shows up in the tables is with that device character that says synthetic substitute unicondylar. So that's very helpful, since we see more and more of these unicondylar knee replacements being done because they are a little bit less invasive, they have much quicker recovery time, and that sort of thing. Also, kind of a significant change, there were a whole lot of PCS codes that were counted as OR procedures prior to October 1 that really caused a lot of havoc with DRGs, etc. And so they made quite a few changes, and you see on this slide the list of the types of PCS codes that were changed from an OR procedure back to a non-OR procedure. And you see at the bottom there, infusion device and monitoring device, which were triggering an OR procedure code prior to October 1 that now in many cases are not. Also here on this slide, we see in a couple of areas they had some non-OR procedures that were changed to OR procedures. 4 codes for percutaneous endoscopic drainage of the pleural cavity, and then 18 codes for endoscopic and percutaneous drainage of intracranial sites have now been classified as OR procedures. Now I want to go into, as I said, the things that were learned after studying the first year's data for PCS. First of all, just to start with the impact on productivity, for inpatient records, which of course is where PCS comes into play, the productivity loss they found was 30 to 45%, and I venture to say that a whole lot of that productivity decrease was primarily related to PCS coding, because it is certainly a lot more complex than what we did with ICD-9 procedure coding. And of course, decrease in coder accuracy is definitely an issue with PCS coding, and an increase in quality reviews, because hospitals are realizing that they have got to do a lot more quality review to make sure that the coders understand PCS coding and are doing it in the correct manner. One thing that I want to say too, just as a word of caution about the encoder, be aware of the fact that the encoder is not the Bible of coding, and it doesn't always necessarily, if you have a decision tree encoder especially, it doesn't always necessarily get you to the right code if you don't answer the questions exactly correctly, etc. So it's really important that you not be so dependent on that encoder that, first of all, you have a code book available to verify what you get as an answer to make sure that it's correct if you have any uncertainty about it. And also, I'll just say that I taught a PCS class a couple of weeks ago, and some of the people in there said, well, we just don't worry about it. We just expect the encoder to give us the answer, and they really weren't taking the time to really understand how PCS coding works and how the different device characters and approach characters and body part characters impact one another when you make changes. So I really encourage you to try to make sure that you really understand that clearly, because it's going to be really important as you go forward with different types of procedures that you have to code, to understand that better and not just assume that whatever the encoder gives you is the correct answer. If you get bad patterns going on with a certain procedure, every time you code that, you code it incorrectly, then you have over time a pattern of incorrect coding that you don't want to set up. And obviously anatomy is very critical with PCS coding, much more so than what we've ever had to worry about with ICD-9 coding. And you need to understand the disease processes that you're coding. You need to understand anatomy. You need to understand what body part is being operated on in different procedures. And that gets complex sometimes when you're looking at blood vessels and nerves and orthopedic bones and joints and that kind of thing. So it's very, very important, especially with the top PCS procedures that you code regularly, that you are very clear about the terminology and the anatomy involved in those procedures. Because if you do not choose the correct body system and correct body part, it can have a huge impact on whether the code is correct or not and what the DRG reimbursement ends up being. For those of you that are, you know, overseeing coders, it's important to have refresher courses offered to them on a regular basis about specific diseases and procedures that they're having to code regularly. So one of the things I found a lot of confusion about is the character for the body system itself. And one of the errors that they found happening pretty regularly was excision of a malignant melanoma being coded to the body system general anatomic region, body part arm. And you can see the code there on the slide and the DRG that groups to. Is that correct? No, it is not, because melanoma is a cancer of the skin and subcutaneous tissue. So the body system for that, and I particularly put subcutaneous tissue and fascia here because typically they go below the skin level with a melanoma excision because of the severity of the melanoma. So typically it is going to be coded to the subcutaneous tissue and fascia body system. And you can see of the arm, and you can see the code there, and you can see the impact on the DRG. It does group to a lower weighted DRG than if you code it to the body part of arm and the body system of general anatomic region. But obviously that is the correct way to code it. And the other thing I want to remind you of, which still causes confusion with all of this, is that unlike in ICD-9, where skin and subcutaneous tissue and fascia were all rolled together in the codes, in PCS, skin is a separate body part from subcutaneous tissue and fascia. So it's really important to read your operative report and determine the depth and level of excision so that you get the right body system and body part coded in the procedure. Also, just as I said earlier, an increased need for really understanding the procedures that are being coded and really knowing how they're done. And you can develop a lot of websites that can help you. There are YouTube videos out there and a lot of websites like the National Institutes of Health website and the Merck Manual website, and some of those websites that really walk you through how these procedures are performed and actually let you watch them online and that kind of thing. And that's really critical for some of the more complex procedures to understand that. In particular, coders were struggling and are struggling with vascular coding, especially AV grafts and fistulas, angiography, choosing the correct root operation, which of course is critical, the correct approach selection, and a lot of confusion still about the diagnostic qualifier X for things that are done for a biopsy. It's very important that you do know the coding guidelines that came out in 2017 in all the new coding clinics. Again, if you have an encoder where you don't have those showing up on the screen for you and you have to go out of that screen, the coding screen, to look those up, please take the time to do that. If you do not keep up to date with the coding clinics that are coming out, especially for PCS, you are not going to be able to code correctly because they are making changes all of the time based on all the questions and confusion that people have about certain procedures out there. And it's just very, very important that you stay up to date with all of that. Critical that you understand the root operation definitions, and what you need in particular to hone in on are what are the differences in them, because you'll have 2 or 3 root operations that will sound similar, but they have distinct differences, and you need to understand what those are. You need to understand which root operations apply only to devices and know what is considered a device by PCS definition. And as I said, you need to develop reputable resources for reviewing coding examples and scenarios and that type of thing. So the number one question to determine what the root operation should be for a procedure is, what is the intent of the procedure? What are they trying to do? And the first root operation I have listed on this slide is excision versus resection. Those are two of the more common things that you're going to be coding in PCS. And the number one issue between those two is whether they remove the entire body part or not. You cannot go by what the physician says in the operative report, because they often use the word resection when they don't take out the whole body part. And one of the best ways to determine how PCS determines the body parts is to look in the index, because there's a lot of guidance in there when you look up the procedure that you're doing as to how PCS defines body parts. And so it's very important. For example, you'll find that the pylorus of the stomach is considered a separate body part from the rest of the stomach. You're not necessarily going to know that unless you are very familiar with how the index divides those things and the body part key and that kind of thing. And also it's important to remember that excision and extraction remove body parts, unlike some other operations that remove other things. The junk group is where you take out solids, fluids, and gases from a body part. And extirpation is one of those that, of course, we've never heard of before PCS came along, where you're actually removing foreign objects from a body part, such as a blood clot. And then you have the cutting group, which involves cutting or separation. And in particular, two of those that are going to fall in that category are division versus release. And you have to understand the differences between those two, and also how those are distinguished from excision, where you're actually removing a piece of a body part. So it's very important that you understand the differences in the definitions and the differences in the intent of those root operations. Here's an example of that. This is a fasciotomy, which is one of the more complex little procedures to code. The term fasciotomy, you know, of course, if you know your the endings of your words, otomy typically does mean incision, as opposed to ectomy, which means excision. And in this particular example, this patient had a 4-compartment left lower extremity fasciotomy. They had an ischemic leg, which means that something was cutting off the blood supply to the leg. And if you've seen any of the medical TV shows out there in the last year or two, almost all of them have had something like this, where the patient was about to lose their leg because something was blocking the blood flow. So in this particular case, they did a 4-compartment left lower extremity fasciotomy. When you look up the word fasciotomy in the index, it basically gives you 3 operations to consider. One of them is division, one of them is drainage, and one of them is release. And then you also have to figure out, well, did they actually do an excision here, or, you know, what did they do? As we read through this little procedure here, you see that they did 4-compartment fasciotomies, exposing the musculature of both the lateral, anterior, and the deep and superficial posterior compartments, and those were viable. So, based on what they're actually doing here, the intent of this procedure is to release the stricture where the muscles are really causing a stricture in the compartment and preventing the blood flow through the leg. So the answer for this particular scenario would be the root operation release. The body part would be muscle of the left lower leg. And in this particular case, because they did it in 4 different compartments, you would actually assign that code 4 times. In order to show the work performed by the surgeon, because all that groups to the same body part, there's no way to show that they did that 4 different places, 4 different times, without assigning that code 4 times. Another interesting root operation in PCS is repair. We use repair a whole lot in ICD-9, but in ICD-10-PCS, it's kind of the root operation of last resort. It's basically restoring a body part to normal anatomic position and function, and you use it only when there is no other root operation that is more specific, that does not apply to your situation. And one of the comments about the tables for repair, it always says no device in the device character. And you need to understand why that is, because it is, as I said, very important for you to understand what root operations apply to devices and which ones do not. The device group must always involve a device, and there are 6 root operations in that device group. I did not list them on the slide for you. I apologize for that, but they are insertion, replacement, supplement, removal, change, and revision. And removal and revision are only coded for devices. Supplement is kind of the partner root operation for repair, but repair does not involve a device, and supplement does involve a device. And it also is important to understand, and this causes confusion with coders as well, that devices can include free grafts. We like to think of devices as made of Teflon or metal or something like that, but a free graft can also be considered a device in PCS. For example, when you do cabbage grafts and you do a saphenous vein graft, which is a free graft, that is considered a device in PCS. However, when you do an internal mammary artery graft in cabbage, where it's a pedicle or flat graft, that is not considered a device because one end of that vessel is not separated from the body like the other one is. So it's very important that you clearly have an understanding of the difference there. Also, tube root. Anytime you have a tubular body part that's being operated on, that's where you need to start in terms of what root operation you need to take a look at. Basically, what I'm trying to get at with all of these issues with root operations is how do you sort of eliminate as many root operations as you can when you pick up an operative report so that you can hone it in between just 1 or 2 or 3 root operations. And eliminating the device groups, or if you are working on a device, only looking at the device group, for example, makes it much quicker to hone in on what the root operation might be for your procedure. A lot of also coder confusion about tissue flaps and grafts. All of these that I have listed on the slide look like they could work, but they all have very distinct objectives and definitions that you need to be familiar with. For example, transfer involves pedicle flap grafts, like I talked about the internal mammary artery graft, and does not involve a device, but replacements always involve a device. So it's real important to understand those distinctions. The moving group is where you put in, put back, or move some or all of a body part. And that includes 2 things, primarily reposition and reattachment. Again, important to understand that reposition is only involving body parts, not devices. And reattachment is coded when a body part has become separated from the body, not by the surgeon, but by some accident or injury or something like that. So here's a little another coding scenario. The physician termed it as repositioning of a pacemaker electrode in the right ventricle. So the question is, what root operation would apply, reposition or revision? We just saw on the previous slide that reposition only involves moving body parts, and we're talking about a device here, so obviously we cannot use reposition as our root operation. So revision would be the correct root operation in this case. And what body part are we talking about? And again, we're talking about a pacemaker in the right ventricle, so the body part would be the heart. Also, abdominal aortic aneurysm repairs with endografts. A lot of confusion out there among coders about how to code that, about which root operation it would be. Occlusion, restriction, supplement, repair, or replacement all look like possible candidates for fixing an abdominal aortic aneurysm. But again, you have to look at the intent or objective of the procedure. What they found, a lot of coders were coding that particular procedure to replacement, and you see the definition there on the slide for that, and you see the MSDRG that it related to. If you look at that definition, that's not really what the intent is when you're trying to repair an abdominal aortic aneurysm, is to put something in that takes the place or function of that body part. Also, supplement. That kind of looks like a good one too, because you're putting in a stent. Usually, we looked at those different types of stents a few minutes ago, and it kind of sounds, like good, but again, that is physically reinforcing or augmenting the function of a portion of a body part, and that's not really what the intent of this repair is either. You can see that if you code it to that, gives you even a different DRG than the replacement did. The correct root operation for repair of an abdominal aortic aneurysm is restriction, where you're partially closing an orifice or the lumen of a tubular body part. Again, I talked to you earlier about if you're doing something on a tubular body part, you need to look at the root operations that apply to tubes first and foremost. And in this particular case, you are trying to partially close that aneurysm so that it doesn't expand and rupture, but you also want to make sure that it's left partially open so that the blood can continue to flow through the vessel. And you can see again that when you code it to restriction, you get that MSDRG 269. So again, important to realize how much the root operation can drive the DRG assignment. At the bottom, you see several coding clinic references that they refer to abdominal aortic aneurysm repair. Another issue, as I talked about, was AV fistulas and grafts. Again, revision can include correcting or malfunctioning a device by taking out or putting in part but not all of the device. And you need to understand that fistulas are not devices and grafts are. Basically what they do with an AV fistula is they are changing the route of blood supply or blood flow through the vessel. So we're talking about a tubular body part root operation. Usually it's going to be bypass. And they take an artery and a vein and they hook them directly together. Therefore, it is not considered a device. Whereas the AV graft is where they are taking an artery and a vein, but they are hooking them together using some graft material, usually made out of Gore-Tex or Teflon tubing, so that makes it be considered a device. So in that case, the root operations that you're going to look at are going to be device root operations, such as supplement, or if you have to replace part of a replacement. So it's very important that you understand those distinctions so that you can choose the correct root operation. Another area that's caused confusion is with spinal fusions and spinal surgery. Be aware of the fact that fusions are coded to the body part joint, not to the individual vertebrae involved. And a vertebral joint has two parts. It has a vertebrae on the top and the bottom with a facet joint in between. But all of that is considered a single joint when you're counting the body part values. Also with spinal decompressions, you're having to think about what body system is involved in that. They usually do multiple levels when they do decompressive laminectomy, such as C4, C5, and C6. But be aware of the fact that what they are releasing, because those are coded to release, the root operation release. For a cervical decompressive laminectomy, it is coded to release of the spinal cord. And for a lumbar decompressive laminectomy, you're actually releasing the lumbar nerves. And again, you've got some coding clinic references on the slide. Another area of confusion is lymph node removal, whether to code excision or resection. And on the left side of that chart, you see what would be considered excisions of lymph nodes: a sampling, a biopsy, a sentinel node removal, or excision, or isolated nodes. Whereas on the right side, things that would be considered resections would be a chain or a level of a lymph nodes, a radical resection, or a modified radical resection. All of those would be considered resection of lymph nodes. Lysis of adhesions is another area that can cause some problems. You have to think about the specific body parts that the adhesions are attached to. And as I said earlier, PCS is very specific. The duodenum, the jejunum, the greater, and the lesser omentum are all separate body parts. Abdominal wall, peritoneum, and the ascending, transverse, and descending and sigmoid colon are all considered separate body parts. Be aware also that there's a coding clinic that just came out first quarter of 17 talking about peritoneal adhesions that you want to take a look at, because in some cases you're going to go with kind of the broader body part and the less specific body part depending on what's happening in your operative report. Multiple procedure guideline, that still continues to be a source of confusion because it's sometimes very difficult to figure out how many different things am I going to code separately in this operative report. A general summary about multiple procedures is, a summary application would be if you do three biopsies of the sigmoid colon, it would be one code because the root operation is the same and the body part is the same. 2 excisions of the same lobe of the lung. Again, the same root operation, the same body part. If you start doing different root operations or different body parts, then you have to start adding multiple codes, obviously. It's important to know what procedures are considered part of the approach and or what things are considered integral to a procedure as well. On this slide, I have a little bit of guidelines for you in some areas. If you do a laminectomy and a discectomy, the discectomy is the only thing that will be coded in that particular case. The laminectomy is integral to that process. For a hip replacement, obviously the hip joint is included in the replacement. And I didn't get this on the slide, but first quarter 17 coding clinic also talks about knee replacement and patellar component and reiterates that the replacement of the patellar is integral to the knee replacement and not coded out separately. In a CABG, hypothermia, cardioplegia, intraoperative pacing, chest tube insertion, all of those are integral to that procedure and not coded out separately. And in a spinal fusion, the fixation, the rods and plates and screws, those are all integral to the spinal fusion and not coded out separately. Some things that are coded out separately, if you have a spinal fusion plus a discectomy, you are going to code both of those separately. The cardiopulmonary bypass is coded separately for a CABG. And just a word of caution about that, they used to always use the bypass for CABGs, but now probably about 50% of those are not done with bypass. They'll document it as off-pump bypass or a beating heart bypass. So make sure you watch carefully to see whether pulmonary bypass was used or not. And if you have a robotic assistance in a procedure, that would also be coded out separately. Another area of confusion, especially with the body part character, is CVLs, PICC lines, VADs, and midline catheters. CVLs and PICC lines are inserted into the superior vena cava or the atrium, and those are coded to device character infusion device. They're inserted in a different place, but they end up in the same place. And there's a lot of stuff out there in coding clinic and elsewhere that you are coding those to where the catheter tip ends, and that is the superior vena cava or atrium. I still see a lot of coders that are coding them to the site of insertion rather than where the catheter tip ends. If you have a tunnel CVL or a PICC line, this is also causing a lot of confusion out there right now and a lot of differing opinions about this, because that tunnel portion of that throws that procedure into an OR procedure for certain diagnoses. But from everything that I have been taught and read and seen, it does require 2 codes to code a tunnel CVL or PICC line. The catheter itself is going to be coded just like the regular CVL and PICC line, where you're going to code insertion of an infusion device coded to where the catheter tip ends. And then the additional code for the tunneling is insertion, subcutaneous tissue and fascia, vascular access device, percutaneous. If you look up tunneled CVL in the index, you actually see that instruction where it says to use vascular access device, subcutaneous tissue and fascia. And the same thing with a VAD, a vascular access device. Again, 2 codes are required, one for the catheter insertion. Again, similar to where the CVL and the PICC line are, typically that does reside in the superior vena cava or the atrium. But the vascular access device itself is going to be put 99.9% of the time in a subcutaneous chest pocket, and that will be coded to an open approach rather than a percutaneous approach. With all of these devices here, again, you're typically going to have an X-ray to confirm the location of that catheter so that you know how to code it. However, they did also have a coding clinic that came out first quarter 17, and it was talking about placement of a central catheter via the femoral vein. And they go on in the question to state that many physicians state that imaging verification is not required when they do that versus the femoral vein. So the answer now, if you do insert a CVL through the femoral vein, is that you are going to code it to insertion of infusion device lower vein. And that's not femoral vein, but lower vein. If you don't have anything in your chart to tell you where the catheter ended, that's the default code. And again, that's in first quarter of 2017 page 31. And the other thing that I wanted to also talk about briefly is the midline catheters. Those are inserted in the upper arms of the veins, like the basilic or the brachial and cephalic. They're much shorter than a CVL or a PICC line, and they terminate typically in the same vein that they insert them into. So if you don't have anything in your documentation to state otherwise, midline catheters are supposed to be coded to the site of insertion. And again, there's several coding clinic references that you can look at for that as well. The midline catheters typically are done by RNs. They're much less invasive than the CVLs and PICC lines, so they don't have to have a separate team to do those, and so they're not nearly as invasive or complex. So a little example here for a hemodialysis catheter on a chart that I was reviewing. You can see that the coder coded this to insertion infusion device of the right internal jugular percutaneous. And the question is that the correct body part? When you go back up there and read the little scenario, it says that the tract was dilated and a triple lumen hemodialysis catheter was placed with the tip at the cavo-atrial junction. So in this case, it specifically tells you where the catheter tip ended, and that should have been coded to the cavo-atrial junction, which per coding clinic is coded to the superior vena cava. So that is not the correct body part for that particular scenario. Another little example here, this is one that we just kind of referred to with that coding clinic about the femoral vein catheter insertion. Again, this catheter was coded to insertion of the left femoral vein. There was not a chest x-ray to confirm where the catheter ended. The H&P and consult had indicated that they were placing a CVL. So again, the correct body part per that coding clinic that I just mentioned a minute ago is the default code here, not coding it to the left femoral vein, but actually coding it to the lower artery vein would be your default code if you do not know where the catheter ended. Another thing with body part, there are certain areas that are complex. Anything done with the lungs and the bronchus is really complex because physicians really do not clarify for you very often whether they're doing a lobe of the bronchus or a lobe of the lung. It's very difficult to tell in many cases. So it's very important. Obviously, if you're taking out a mucus plug in particular, which is going to be coded to extirpation, it makes a huge difference in the DRG if you code it to lobe of a lung versus lobe of a bronchus. And you can see on the slide there that the lung would code to a DRG with a relative weight of 1.7898 as opposed to the bronchus 0.7028. So it's going to be really important that if you absolutely cannot tell, obviously anatomy is important, but I think there are 5 lobes of the lung and I think 4 of the bronchus, and it's just really difficult sometimes based on the documentation. So important that you get the doctor to clarify that for you before you code it if you can't tell which one of those was involved. Also, BAL, bronchial alveolar lavage. This was another chart that I was reviewing at some point in time, and in this particular case you read that this BAL was performed into the right middle lobe. They took out 90 cc's of, or a total of 42 cc's of cloudy effluent, and then they put the scope into the right upper lobe and lower lobe bronchial tree, and then they went in the right side and the left side to look around and see what was going on. And you can see here that the coder coded drainage of the left lower lung and right lower lung, and drainage of the right upper bronchus and left upper bronchus. But I do not see that they did drainage anywhere except in the right middle lobe. So then the question, in the rest of it, they're basically just inspecting the bronchial tree rather than actually doing any drainage. So those things are already wrong. But the other issue with this is, are we talking about lung or bronchus here? And again, they had a correction in first quarter 2017 about this. They had a coding clinic in first quarter 16 that was talking about BAL was performed on the bronchus. But the correction in first quarter 17 is stating that a BAL involves washing out the alveoli, and that the correct body part for a BAL is lung. So the answer for that scenario there would be drainage of the right middle lobe of the lung and then inspection of the tracheobronchial tree. Approaches are another area of confusion sometimes. It's very important that you understand in particular the difference between open, percutaneous, and percutaneous endoscopic. Last year they found that a lot of coders were coding insertion of leads for a pacemaker to percutaneous endoscopic approach, and that was not grouping to a pacemaker DRG. They do not use a scope when they insert a pacemaker lead. That is a percutaneous approach, and if you don't get the approach character right, you don't get the right DRG. But it gets tricky, especially when you're talking about something that starts out percutaneous or percutaneous endoscopic, and then they have to extend it to an open procedure. And it just really is confusing at times. And this is especially starting to be a problem with hand-assisted laparoscopic procedures. There is a coding clinic out there that basically tells you to code all of those to percutaneous or percutaneous endoscopic, I guess. But there are some cases where, or maybe it tells you open. You know, it's very, I don't really even remember what the coding clinic says right this second, but it just has one approach character for all of those procedures. And when you read those procedures, it's really not clear. Sometimes it's not that clear cut. So it's going to be important to kind of read your operative reports carefully and also maybe write into coding clinic for some clarification about that. Same thing holds true for burr holes. They have, I think all of those, they're stating code to percutaneous, but some of those appear to be more open. And so again, it's important to read carefully the operative report that you're looking at and write into coding clinic if you need clarification and or get clarification from your surgeon before you code those situations. Another area that's caused a little bit of confusion is arterial lines. We have on the slide some coding clinics that have guided us along the way. Second quarter 16, page 32, talked about arterial lines and coding to insertion of a monitoring device of the upper artery percutaneous approach for arterial catheters that are not, it indicates that you code the insertion of the device, but you don't have to code the continuous monitoring. And this is when they're done for continuous hemodynamic monitoring during surgery, in ICU, doing repeated blood sampling, blood gas analysis, etc. However, there was also a code write that came out in June 2016 and a coding clinic on the the next page after page 32 in that second quarter 16 that says if you're doing an arterial line for just continuous blood pressure monitoring, to code that to monitoring rather than insertion. And it also goes on to state that those are not really required in the inpatient setting. So make sure that if you're coding arterial lines in your facility that everyone is on the same page about how you're going to code those, when you're going to code to insertion, and when you're going to code to monitoring, etc. Device characters are also an issue at times. In this particular little scenario, the coder coded this to synthetic substitute of the lumbar vertebral joint. However, when you read the scenario, basically what they did was take fixation device stuff out. So the character should have been an internal fixation device, not a synthetic substitute. The second part of that procedure was when they went in and had to do re-instrumentation and fusion of some segments. And again, they coded replacement of the lumbar disc with synthetic substitute. And when you go up there and look at it, you see that they had bone aspirate from the iliac crest performed and mixed with Vitas. And when you look at the coding clinic guidelines for that, and let me find that, it says that if you have mixtures of autologous, which is what the bone aspirate from the crest would be, and non-autologous tissue, you would code that to autologous tissue rather than synthetic substitute. So that was coded with an incorrect device character. Qualifier. Cemented versus uncemented. This is just such a pain to have to figure out, and surgeons get really angry sometimes when you say, when you ask them to clarify whether they use cement or not. One surgeon said, do you really think I'm going to say I didn't use cement? However, Coding Clinic came out third quarter 16 and does reiterate once again that if you don't have documentation of cement, you either are going to have to query the physician about that or assign that Z qualifier, no qualifier there. Also qualifier X, again, as I said, it's important to make sure that you understand the purpose of procedures that are being done as to whether they're diagnostic or not. What is the nature and intent of the specimen? First of all, be aware of the fact that anytime they take out fluid and send it to the lab for cytology, that does not automatically indicate diagnostic, because they're always going to do that. Every time they take a specimen out during an operative episode, they're always going to send it to pathology, but that does not mean that that automatically determines that the intent of that procedure or that removal was diagnostic. So it's important that you clearly read what's going on and determine what the intent was. If they take out an entire lesion, it is considered a therapeutic procedure. Paracentesis can also be a little bit complex because both diagnostic and therapeutic paracentesis is done. Typically with diagnostic, they're going to use smaller needles and take out just milliliters of fluid, whereas in a therapeutic, they're going to take out greater than 5 liters many times, and they're going to use much larger needles for that. Important also to understand for OB procedures the difference between what is coded to the OB section and what is coded to the Med-Surg section. The OB section procedures all start with a 1. Those are only assigned for procedures on the products of conception or following delivery or abortion. The things that are done to the mother during delivery, such as an episiotomy, repair of perineal lacerations, or diagnostic or therapeutic D&C done other than postpartum or post-abortion, are going to be coded to the medical surgical procedure codes, which start with 0. Some other things about OB, epidurals are not coded out separately in deliveries, and lacerations of repair, it's not really sufficient anymore just to code repair the perineum. They really want you to code to the degree that's stated. You kind of see the degrees listed on this slide for you, and I have been advised that if the doctor states 2nd degree, it's still important that you read the procedure and actually read what he repaired in order to assign those degrees appropriately. And again, several coding clinic references there. If you are doing an EGD and they don't specify the site that was viewed, code to upper intestinal tract, which is typically what they look at with the EGD, unless inspection of a distal portion of the GI tract is documented in your procedure. And again, you have a coding clinic reference. Also, be aware of the fact that a CT scan and a CTA are different, because the CTA is actually looking at the vessels, and there are a couple of links there that you can take a look at to look into those procedures, but those are coded differently, so make sure that you understand the difference. Also be aware of the fact that the title of the report is usually created by an order that's attached to the charge master and entered by the tech, and it doesn't necessarily adequately or accurately describe what they actually looked at in the report. So try to look at the report and code it as closely as possible to what things that they actually looked at, and also determine whether they used contrast or not. Also, if you're a facility that codes MRIs with and without contrast, would be coded to enhanced and unenhanced in PCS. And with that, I will turn it back over to Karen to see if we have time really quickly for any questions.
Thank you, Joy. That was a lot of really great information. We do have a couple of questions, and I'm going to start off with questions that people had, about your actual presentation. So one of those is on slide 39. I don't know if you want to go back to that one, but that's the one about the BAL. And yes, they had a question on that one, and they asked, is the inspection considered inherent to the BAL on that one?
Not in that particular case, because they went in, to that right middle lobe and drained it, but then they went in there to look at all the other lobes to see what was going on in there, and they state, I think, in there that there was a lot of sort of inflammation, and it was hard to see everything. But I think in that particular case, that inspection of all the other tracheobronchial tree was a separate intent than what they were doing with that drainage of that right middle lobe.
Okay, thank you very much for that. That's a lot of good information. Thanks. Someone had asked about how to code a robotic assist, and I actually looked up that procedure code while you were talking. The robotic assist is going to be the table 8E0. 8E0 is the table that'll get you in the robotic assist. And there's not a coding clinic on that, but basically there was something in the AHA coding handbook that said that you would code robotic assist in conjunction with the main procedure. So I don't know if you want to say anything else about robotic assist procedures.
That's great, but thanks for looking up that code for me, Karen.
Sure. Didn't want you to have to do that too. Someone else had asked if we could repeat the 6 categories in the device group. I did not have time. Do you have that on that slide where you could pull that up real quick?
Yeah, let me go back and find it real quick.
Thank you.
Okay, insertion, replacement, supplement, removal, change, and revision.
Okay, thank you very much. I have a question too. Early on you were talking about making sure that people, if they were using encoders, making sure that they were really watching the encoders and that they had all the information. So I know there's different types of encoders out there, but like for example with TruCode's encoder you have all the resources there. I know you've been using that normally. Does that help you a lot using the encoder, the knowledge-based encoder with TruCode? Is that helping you find things a little easier?
Well, it does. First of all, having the resources right in front of your face is excellent. But the other thing that I have found about that has helped me a lot, this came into play with a procedure that I was reviewing recently where the body part affected the device characters that were available or the approach characters that were available. And in this particular case, they were doing cauterization of the nasal terminates to stop a bleeding, and it wasn't a control situation with acute bleeding, but it was coded to the cauterization or destruction. And the coder coded it to nose, and she coded it to a percutaneous approach, but what they actually did was to go up through the nose with a scope. TruCode has those laid out so that they open up one character device at a time. Like when you first look up the procedure, you'll typically get the first 3 or 4 characters there, and then it opens up the approach character and the device character, et cetera, one at a time. And so when I had the body part of nose listed there and I saw that the approach that actually occurred on my operative report was not accurate, I started playing around with the body parts, and when I clicked on nasal turbinate, which is what they actually cauterized, then the approach of going through the nose with a scope opened up for me. Same thing holds true sometimes where you'll have a different, depending on the body part or the approach, you have different characters, device characters that open up. And so the fact that you can see all of that one at a time with those tables in TruCode is extremely valuable to me to see how they're interrelated with each other and to help you figure out whether using a more generic body part or a more specific body part affects whether you can code the device that you need to code or the approach that you need to code, etc. Hope that was clear.
Yeah, that's great. Thanks for clearing that up. I appreciate that. I think we have time for one more question, and that is, someone wanted to know, do you think, because we had fiscal year 2016 and then now 17, do you think that CMS or commercial payers are going to be requesting refunds that occurred in fiscal year 16 for operating room procedure DRGs that are now considered non-OR procedure DRGs this year? So do you think
that's a good question. I would really hope not. And I will say that because I read somewhere about some procedure that was classified incorrectly and it was getting denied payment, and CMS basically said, we're not going to go back and recoup you, so just try to rebuild that one at a time with your MAC. And since they're not willing to go back and kind of recoup hospitals, surely they won't come back and ask hospitals to give them money. So I don't have any reason to think that's going to happen. Then once they make the change, they're going to go with whatever the reimbursement is going forward, but I don't think they're going to go back and do that. I hope not anyway.
Yeah, me too. We do have one more question that I think can be covered, and that is they were talking about an extirpation of a hematoma. Oops, I'm sorry, it went away from me there. Would you code that as an extirpation, or would you code that as a control with a hematoma?
Well, a hematoma I don't think would be considered acute bleeding because it's a blood clot basically. So the difference there with a hematoma, and there was actually a coding clinic, and I think it was maybe third quarter 16, where you were trying to figure out whether you would code drainage or extirpation, because some of those, the difference between drainage and extirpation is whether it's still sort of liquidy or whether it's solidified into a solid mass. So that's the kind of thing that you're really looking at with a hematoma. I think that coding clinic was specifically talking about subdural hematomas, but I would not ever code those to control, because I don't, as I said, a hematoma typically is kind of a blood clot where the blood is kind of confirmed within or contained within a sac, so to speak, and it may still be liquidy in the sac, or it may be more gelatinous or solidified. So again, I think you would consider drainage or extirpation as your two options.
Okay. Well, thank you very much. Well, we are out of time. That was a wonderful presentation. And so remember, those of you who have some questions, we will try to get to those and send you the answers after the presentation today. Remember, your handouts are there. You'll be getting the evaluation form tomorrow. Thank you so much for joining us today, and thank you, Joy, for another wonderful presentation. I hope everyone has a wonderful day. Bye now.